Welcome back to the Journal Club of Justice, an online journal club made up of a small group of friends who meet once a month to praise, scrutinize, and discuss research of the physical therapy nature, one article at a time. Could be new, could be old, but we feel it will create a good discussion that will influence our practice. We hope that you will get as much out of this as we do. We do ask you keep in mind new research is always coming out and progressing, so do not take any of what we say as medical advice, facts, or clinical suggestion. Here we are, episode 4 of the Journal Club of Justice. This month we are talking about low back pain and women's health conditions. Yes, you heard that right. We are fortunate enough to have a member with a women's health interest on board with us, Dr. April Winthy. My name is Dr. Adam Schwartz of Run Mental. Also accompanying me for this episode is student physical therapist Emily Malk to my left. And then to the left of her is Dr. Dylan Callier of the New Medical Nomads podcast. So nearly 2/3 of Americans experience low back pain, according to the APTA's Move Forward Low Back Pain Survey. And low back pain costs a lot of money with all the costs related to treatments, imaging, medical professional visits, etc. And we know the work from Childs and Fritz et al. In 2015 that early intervention, specifically getting physical therapy within 2 weeks of an episode of low back pain, results in 60% lower total low back pain related costs. This goes to show that not only is it important to find the right treatment, but finding it in a reasonable time frame is often key. With this in mind, let's take a look at this month's article, which is entitled Intermittent Low Back Pain Referred from a Uterine Adenomyosis, a Case Report. And this was published in the Journal of Chiropractic Medicine in April of 2010. So April, do you mind giving us a little backstory on why you chose these articles, how you found them?
Sure. So I am really interested in women's health, and as we all know, in the outpatient ortho setting, we see a ton of people with low back pain and leg pain. So I was preparing for an in-service for my colleagues, and I'm also doing a continuing ed course in the spring. And I wanted to bring to light to just the general outpatient ortho PT that patients' low back pain and leg pain may be coming from endometriosis. It's considered rare, but it could be coming from that. So when we ask questions regarding their back pain, I wanted us focusing too on asking if it's a lady, is it related to their menstrual cycle at all? Because if so, it could be endo. So that's why I started looking into more research articles, because I heard that that was a possibility. So I was just trying to find some articles that related to that. And I came across several, and this one, a pilot study, and then another one. None of them are specifically related to physical therapy. There may be some out there, but the ones I found were just more general and like chiropractic, and then also with the Endometriosis Association.
Very good. All right, so let's dive in a little bit. April, do you want to give us kind of a brief overview of what endometriosis is?
Sure, let's talk about that first. So that is when the endometrial so that's when the endometrial tissue in the uterus grows outside of the uterus or grows deeper into the muscle wall of the uterus, and it can cause abdominal pain, like severe abdominal pain, low back pain, groin pain, pain with intercourse or dysmenorrhea, and it can also just overall, it can like make people go disabled because of the severe pain from it. So typically it's diagnosed with laparoscopy, but when people have that done, it's just creating more scar tissue as well in the abdomen. So it doesn't just like the diagnosis affects people too, because they're getting more scar tissue in the abdomen.
Gotcha. All right, so like we mentioned, this is a case report. So maybe you guys want to go over kind of what the demographic of the patient was. So this was a 45-year-old Caucasian woman, nulliparous. What did they say that means? Mm-hmm. What that means again?
She hasn't had any children.
Hasn't had any children?
Yeah.
April, You with us?
She's frozen.
She's frozen. Gotta love the internet.
She's back.
Okay.
Okay. April, Noli Paris. She hasn't had any children.
Yes, correct.
Yes.
Yep.
Okay.
Oh, neat. I didn't know that.
All right.
Yeah, you're correct. Sorry, my freezing.
That's okay. So this patient, their chief complaint was diffuse low back pain of 4 years intermittently. She had concurrent marked low back pain and cramping mainly on the right, but also on the left, and extremely heavy menstrual flow. Her pains were often related to the menstrual cycle, but not always. Anything else that popped out with you guys as far as the individual?
She was also obese.
Yes.
Her BMI was 30. So, as we know, that can also play a role in low back pain.
Mm-hmm.
And I think it was important too that nothing specifically like caused the pain.
Oh, yes.
Right. Yeah. No mechanism.
Insidious.
Kind of like a red flag for us treating low back pain, like it's musculoskeletal.
Yeah, and they also mentioned that she reported the pains originally starting after relocating to a different city for work. So I mean that's a big like life stressor and just her general ecosystem around her. Which is going to play a role in that sort of the psychosocial kind of aspect of her development of pain. And then another question for you, April.
Yeah.
Leiomyoma?
So that's just like a uterine fibroid. So those are actually kind of common. And I think at first it said that's why they didn't treat that because the ultrasound first showed like the fibroid. And then she got the ultrasound done 4 months later, showing more the endometriosis or the adenomyosis, which is endometriosis into the uterine wall. Does that make sense?
Mm-hmm.
Yeah. Yeah, her pain was kind of all over the place. Lasts for 1 to 2 days or as long as 2 weeks. It can be mild, rating as a 2 out of 10 pain up to a 10 plus out of 10 pain. So that's pretty crazy.
I don't know where it said it, but she received a lot of complementary alternative medicine as well.
A lot.
Yeah.
Like quite a variety.
In there.
Acupuncture, Rolfing, craniosacral, herbal remedies, functional nutritional therapy, whatever that is, neuro-emotional technique, and Reiki. Reiki?
I think you're right.
Reiki. All of which helped in the short term only. No surprise there.
Well, and typically too, like these women that I'm seeing, not only with endometriosis, but also other chronic pelvic pain issues and like interstitial cystitis, they come in and they've tried so many different things, like just jumping at stuff because the doctors typically don't know to send them to like women's health therapists. They don't really know what to do for their pain. So they just kind of try everything that they can. And I think one of like the pilot study that we were kind of talking about earlier that I found too, I was reading it, and it showed that nearly 50% of the women with like low back and leg pain with endometriosis were not offered any treatment for their symptoms. So these women are going to their doctors and telling them about the pain and sometimes not being referred to anybody else. So then they're just going online and trying to find stuff that's going to help them.
Gotcha.
And it's sad because sometimes imaging doesn't show what's actually going on. With endometriosis, it will show more because you can see it, but like interstitial cystitis, which is another women's health issue, or painful bladder syndrome, no imaging shows that. So these women feel like they're being told it's all in their head. So they jump for anything they can to try to help with pain.
Makes sense.
Yeah, so I did look through that one as well, April.
Oh, that's fine.
And one of, I guess in figure 1, they kind of broke down the pain chart that all their participants filled out. And their distribution of pain were consistent with involvement of the femoral nerve, the gluteal and lateral femoral cutaneous nerves, the lumbosacral plexus, sciatic and or posterior femoral cutaneous nerve, and the lateral femoral cutaneous nerve alone. So I mean, it would be easy to say that this has some radicular symptoms, some lumbar pathology or something to go with, and treat them with that, and ultimately get nowhere because that's not where the root cause of the pain is.
Yeah, so there's a lot of other studies too that we don't have, that we're not really talking about, where it shows the endometriosis attaches to like the sacral plexus, the sciatic nerve, the obturator nerve. So it kind of seems like it's coming from the back, and that's why it's really important, our subjective history, getting from the patient.
April, can these patients kind of present almost mechanical with the muscle or with the lining kind of on those nerves? If they bend over, will they have worse pain?
Yeah. And I think that's too, like, even with this study with the chiropractor, at first they couldn't figure it out. They said it wasn't cyclical, and they were still trying to treat it, more musculoskeletally. So yeah, I think so. And they might show small improvements with the pain, but you're not going to actually fix the entire picture.
Got it.
Yeah, and especially, I mean, this episode of care was pretty involved. I mean, it's twice a week for 4 months.
Mm-hmm.
That's a long time to get care. Mm-hmm. For low back pain. At least I thought it was. So.
Yeah. Because that's what, like about 32 visits. So.
Yeah. It's a lot. So I think go ahead.
I mean, I could we jump all the way to their like discussion or conclusion or whatever? Because that's just was something that I wanted to bring up, was that they kind of thought that her pain was decreased because she was seeing them so often. But to me, that's kind of is it real? I don't know. I don't know what I'm trying to say. Do you know what I'm trying to say?
Yeah, I think so.
I know it.
So would you have preferred that they had like a 6-month follow-up? Like,
yeah,
was what we saw in the clinic carried over, long term, basically?
Yeah.
And I think the answer to that is, I think if they're going to continue to get the treatment, they need to continue to get it. Endometriosis isn't something that's going to, you do a little bit of physical therapy or chiropractic work here, and then 6 months later, the patient's still feeling good. I think that's something that if the endometriosis isn't actually taken care of, the pain's going to come back.
Mm-hmm.
And it's up to the patient. Do they want to continue with more conservative treatments like that, or do they want to have a surgery where they go in and try to clean out all the endometrial tissue? But then even with that, sometimes that tissue will grow back. So.
Yeah. That's a bummer.
Yeah.
Well, it is. I mean, like, what do you do about that?
It's an ugly disease. It really is.
Really, I'm not a women's health interest or specialist or anything, but I think that we don't really have anything to successfully treat this. Is that correct, April?
Yeah, surgery is like the end result, but so you'll have to get a complete hysterectomy, take out all that tissue. And then even with that, I've heard of people where the tissue still grows back. Sometimes they have to go back in and take it out again. And for women that are younger that are wanting to try to have children, you can't go in and do a hysterectomy. You can't do that if you want to give them the chance of having a baby. So.
Okay. So we'll jump into the conclusion like Emily wanted.
Sorry.
No, it's okay. So the big thing here that I took away was that, at least in her case, this was a non-mechanical presentation of her pain. Nothing really provoked it. Nothing really made it better, which goes along with the fact that low back pain is really difficult to identify causes a lot of times, or identify, have a definitive determination of the cause and what we need to do to fix it. And most people with low back pain have low back pain again within the year. So it's not like we have a great understanding of what to do with these patients in general, let alone if they have something more complicated like a women's health issue that is even less known of what to do with.
Mm-hmm. Yeah.
Can I point out some stats from the pilot study that I read?
Yeah, go for it.
It's kind of good. So this was a pilot study done by Missmer and Bove, and it had 94 people with endometriosis. 48 of those people, or 51%, had endometriosis with leg pain. And then 59% of those people had bilateral leg pain. And then the regions of the pain, the number one region, which was 60% of the people, they had pain proximal and anterior, so from the anterior hip down to the knee. 31% had it from the knee all the way down to the foot, like in the shin. And then less common was the posterior aspect. 40% had it posterior from the glutes down to the popliteal fossa, and 47% had it down in the calf. So, I mean, those numbers are pretty high, so it kind of shows it can be anywhere in the leg. And then, of course, we know pain's more present during menstruation or just prior to menstruation. So I just wanted to point those out, that the pain can really be anywhere in the leg. It doesn't follow necessarily a particular pattern like we were talking about earlier. It can be any of the nerves.
Yeah. And especially with that anterior thigh, when I hear that, I'm starting to get down a rabbit hole of, well, maybe the hip's involved, and or maybe it's one of the other distributions or something. And then I'm totally going on a different path, going away from where, maybe it's an endometriosis or something, in which case, that's going to be a hard hole to dig out of once you get far enough down. You're going to get a couple weeks in the treatment and, you've gotten nowhere. So it'd be a lot easier to, have some of those screening questions, making sure we're, asking about menstruation or something, if it is a female within, childbearing years, to not go down that path, and make sure that we're kind of ruling out anything women's health related.
Yeah, and that's what my in-service was, talking to like the ortho PTs of what they need to be asking in their examinations to make sure they're ruling all that stuff out. So I said just simply asking, like not even regarding endometriosis, but just simply asking if they had any like tailbone injuries where they've fallen on their coccyx. Do they have any complications during delivery with tearing or any damage to the pelvic floor region? Because pelvic floor pain can refer pain to the back. So just asking all those questions, and also asking, does it seem to be worse with your menstrual cycle? Just asking all those different questions, so you're not missing anything on the first day, and so you're not treating them for 2 to 6 weeks and not really seeing any true improvements because you miss simply asking one question.
Is there any change with like urination or bowel movements that we should be asking about?
That's a good question. I think bowel movements can be more painful. Regarding urination, I'm not going to say, because I'm really not sure with that. But I should say too, with like we were talking about earlier, interstitial cystitis or the painful bladder syndrome, I've had more women with that than I have with endometriosis referred to me. But the word is just getting out in our community too about women's health. So my patients with interstitial cystitis, they typically have abdominal pain, groin pain, hip pain, and my last one also had pain in the adductors and quads. So we just spent a ton of time on stretching it out which helped her, and she became independent with all that at home. So I discharged her, and she's doing it all at home, and that's something she's probably going to have to do for the rest of her life, because it's a condition that we can't eliminate. But just teaching these women how to take care of it on their own at home. And I know with endometriosis too, sometimes they'll have like more constipation issues. So teaching them how to do abdominal massage, like the ILU massage for their abdomen to help with bowel movements and stimulating that, and just general education on reducing constipation helps too.
Squats.
Deep squats. Deep squats are the best to relax the pelvic floor. Just get down there and hold it.
Yeah, I thought that was
I wasn't
going
sure
somewhere else.
And happy baby stretches are good too for the pelvic floor.
Happy babe. Oh, is that when you like lie on your back? You
And you bring your leg.
Yeah.
Yep.
Interesting.
I was gonna say when I was working in the ICU, we were often called, PT the poop team, because it was the first time you're getting people up standing in 2 weeks. They've been lying in bed, and that's usually like when they had a bowel movement. Just doing that.
Yep.
Interesting. Makes sense.
Okay.
And I apologize. I apologize. This case report. Oh, sorry, Adam.
Go ahead, April.
I was going to say, I apologize that this case report wasn't really physical therapy. It's more chiropractor, so we don't really know the activator methods and all that, but I think it really applies regarding just looking at the back pain and how we can see.
Yeah, it is.
It's like almost like a,
We Googled it. We watched videos.
I can't believe I'm blanking. Not so when you get a shot, there's a needle, and there's where they draw the medicine into. Syringe. There we go. Thank you. So it looks kind of like a syringe, and my understanding is you kind of go to like the end point of whatever the resistance is, and then I think it'll like snap or pop or whatever, and gives a thrust with a low amplitude. So it's just
low amplitude, low power.
It's just a weight manipulation without your hands. Kind of like iStem is doing soft tissue work without your hands. It's a way to do a manipulation without your hands. That was my understanding. Any chiropractors out there listening want to chime in or correct me, feel free.
Popping backs with syringes.
Yeah, and I guess what I found interesting was they reported their results in Table 1, and it said their low back pain, according to the NRS, after therapy during their active cycles, was a 3, and then it went down to a 0 and a 0 and a 0. But it didn't give a time frame on that. It just said after activator methods therapy. So I don't know if that means right after. Because it said within the case report that she reported a reduction in frequency and duration of the low back pain and abdominal pain. However, the severity of the low back pain often remained marked, which I felt kind of conflicted. Because if she had 0 pain right after manipulation, that would make sense. But if it didn't last very long,
Then what's the benefit?
Yeah.
Mm-hmm.
Yeah, she could just use heat and her NSAIDs like she had been doing, that would give me temporary relief. Yeah, it doesn't really say.
As well as consuming a diet high in green vegetables, fiber, fish oil, and B vitamins, and low in red meat, eggs, and cheese. Just gotta throw that out there because it's good to eat your fruits and vegetables always.
And to eat breakfast.
And helps breakfast.
With constipation.
Dylan might disagree with you.
Yeah, no breakfast. Coffee helps with constipation.
That's a bladder irritant. You don't want that.
Okay. Yeah, I thought that paragraph was kind of random.
Yeah.
I thought this
But
whole.
I know chiropractics tend to go more into nutrition than physical therapists.
Nutrition.
Yeah, I thought that paragraph was actually this whole like column really, because they talked about how there's not much literature for non-invasive interventions for dysmenorrhea, endometriosis, and chronic pelvic pain. Then they go into all this stuff about dysmenorrhea, but not the other two. So is there absolutely no literature, or what? Why would you only talk about the one?
April,
Well, I think
is there a lot of literature on this?
I was gonna say, regarding the dysmenorrhea, that can include all like the endometrial symptoms, so like the abdominal pain, the back pain. It's kind of hard to disassociate the two because it is happening when they're on their menstrual cycle. So I think they're categorizing it all together. Don't ask me regarding. I'm not really sure regarding all the research out there on all of this.
Fair enough.
It didn't seem like it.
Yeah.
I mean,
There's a lot more studies.
Yeah,
There's a lot more.
Same thing. I mean, that's the big issue with a lot of this is.
And this came out in 2011, and I think there's, at least for PT, there's a big push for women's health. I feel like within the past 5 years.
Yeah.
It might have been right before, if that trend continued in chiropractic literature, that this might have came out right before that.
Yeah.
And I'll have to search for more physical therapy related articles on endometriosis and see what I can find.
One of the last things mentioned, last few paragraphs of the discussion, it is further theorized that the confidence that the patient has in her practitioner and in her own ability to heal is also of great consequence to her outcome. I don't know that that's a theory. I don't know. In my eyes, I'm reading that as placebo.
I wasn't even thinking that. I was thinking of locus of control, like the personalities that think, just kind of whether or not the world is against them, or if they can, take on the world type of thing. Like if they had their power to, make themselves feel better or get them through the day or strengthen themselves so that they can do whatever they need to do, versus, oh, I need to go to someone. Oh, I need this brace. Oh, I need these pills type of thing.
Yeah, I would agree with that. I mean, maybe a little bit of both. I mean, nothing against placebo. It definitely works. But there's definitely something to say for those patients who expect to get better and know they're going to get better, as opposed to the ones who think, well, I'm just old. This is just going to get worse. And you're like,
it is what it is.
Like, are you listening?
Yeah, and we all have those patients that come into therapy and they don't expect to get any better, and they have a mindset that we're not going to help them at all, and they're not going to get better because they're not going to do their stuff at home. They have it in their mind they're not going to get better. So
on one of my clinicals, one of my favorite questions they had on the medical intake form was, do you expect physical therapy to benefit you? And it was like a scale of 1 to 10. And sometimes you'd have people like, yeah, this is what I need, like 10 circle highlight, and basically just them walking in the clinic made them feel better.
Yeah.
And then you have others, it was like, I can do things and you try and get that buy-in as best you can, but yeah, and there are some studies to show that the patient belief is like the highest correlation on whether or not they're going to get better or not.
And not saying
insidious stuff.
Yeah, and not saying that every patient that comes in doesn't really believe in therapy isn't going to get better. Because I've had several patients in the past month that at the end they're like, April, I really didn't believe what you were telling me that first day. Like, I really didn't think this was going to help me at all. So they're like, look, I'm pain free now. Like, thank you. So.
Yeah, I agree with that.
Yeah, for sure. As long as you are human and you have a pulse, you're going to respond and adapt to the appropriate stress. Not a machine. You're not going to just hit 5,000 miles and break down, or whatever the car, 100,000 miles and break down. I guess it'd be more appropriate for a car.
We're not chiropractic
Yeah.
people.
Yeah. Yeah. And thank goodness, because man, that'd be rough.
Have you read the article on the 5 E's of like patient interaction during treatment?
I don't know what
I have it saved, but I can't remember the 5 E's.
It sounds like an article, dude, down the road.
Yeah. That's what I was gonna bring up.
Yeah. Good deal. All right. Anything else to say about this one?
No.
Was this a case study or a case report?
Case report.
Case report on the title.
By the title. In an abstract, it says it was case study.
Case report.
Yeah, it does.
That there's multiple cases.
That's what I thought.
Right?
Yeah.
So the way I read this is it's more of a case study because there's just one individual.
Yeah. That's
Delineating her care.
Yeah, and it was very causative with everything. And it was this retrospective, right?
Mm-hmm.
Which kind of, they don't have a lot of data and stuff they can go off too well other than their own treatment notes.
Yeah.
But
I mean, case studies kind of just are retrospective.
Yeah, I think so.
You're not gonna, not gonna like prospectively treat somebody.
I think there are cases that you can, but they're very rare. Yeah. And it's like when you get this like, you know it's going to be interesting, and so you start like documenting all these notes. But yeah, it was very correlative. But like I was saying with the women's health interests and things like that, at least coming out of school, I feel like that big boom and that big APTA push wasn't until maybe even when we were in school, past 3 to 5 years. And this came out before that. So that's usually what case studies are for, just to bring attention to a subject so that other studies can follow.
Mm-hmm. Yeah, I guess the biggest thing that I got out of this article was that, the awareness aspect of it, that this is a problem that can cause back pain.
No, keep going.
Did we lose her?
No, she's back.
Okay. This is something that can cause referred pain, and it's, underdiagnosed, but it's more common than we may think that it is. And just to keep something, when you hear these red flags, to keep this as something in your mind too of, oh, it's not something that we can reproduce. It is kind of cyclical, like, asking those right questions, like April said in that first day. So if you go down a rabbit hole, maybe you can pull yourself out because you do have this information somehow.
So April, are you going to perform spinal manipulations on all your patients with endometriosis?
I
don't know.
You there?
Oh,
can't hear.
We lost your sound, April. Where'd you go?
Oh, she's on mute.
She's on mute?
Yeah, you see the little.
Oh.
Do I need to hit that?
No, he was her.
April, is there like a mute button you can hit? There you go. There you go. You're back.
Can you hear me now?
Yeah.
Yes.
Okay, sorry guys.
You're good. Could you hear us?
I was saying, no, I don't do spinal manipulations anyways. So.
But yeah, I agree with what Emily was saying. Just being aware of it. And a couple more questions when you have those patients where it's like, I can't reproduce this thing, or even if you are reproducing it.
It's kind of erratic.
Yeah. It might not be mechanical.
Yeah.
Oh, we lost her again. She's on mute again.
Okay, sorry guys, I'm back. Sorry about that.
All right, so good job, guys. This article was, again, intermittent low back pain referred from a uterine adenomyosis, a case report. Lead author is Jensen, and it was published in the Journal of Chiropractic Medicine back in 2010. So if you guys like this, leave a comment, like it, share it, tag your friends, any people with women's health issues, pelvic pain, etc. You know, contact us if you have any suggestions or comments, topics you want us to cover, want our thoughts and opinions on. We'd love to give it. We'd love to talk about it, kind of discuss some more and learn. This is, to my far left, is Dr. Jillian Collier of the New Medical Notes podcast. Check it out. Emily Malk, a student physical therapist, so got one more year. I'm Dr. Adam Schwert of Run Mental. And then our special guest today was Dr. April Winthy. I think we're good. All right. So until next time, you guys have a good
Ritz now.
Dr. Ritz.
Dr. Ritz now. Oh, yes. I'm sorry. Dr. Ritz now.
Come on, Adam.
We'll get it right next time. All right, this is the Journal Club of Justice signing out.